Welcome everyone to Medicine Grand Rounds, and this week's presentation will be the first of two joint Medicine Global Health Grand Rounds. And our speaker today is Dr. Kevin Kain from the University of Toronto. And to introduce Dr. Kain, I'll turn it over to Dr. Jason Bestie from the Department of Medicine and the Department of Global Health.
Well, thank you, Dr. Lyles. I really appreciate it. And as Dr. Lyles mentioned, this is on the behalf of the Department of Global Health. I'd like to welcome all of you to our very first joint Global Health Grand Rounds of this academic year, co-hosted by the Department of Medicine and the Department of Global Health. And as Dr. Lyles mentioned, this year, the Department of Global Health and Department of Medicine will have two joint Global Health themed Grand Rounds, including today's Grand Rounds and again this spring. It is my pleasure to introduce you to our Grand Round speaker today, Dr. Kevin Kain. Dr. Kain is a clinician scientist and a professor of medicine at the University of Toronto. He is the director of the SAR Laboratories, Sandra Rotman Center for Global Health, and holds a Canada Research Chair. Dr. Kain began his research career as a senior research associate at the Walter Reed Army Institute of Research in Washington, D.C., working on field trials of the first generation of malaria vaccines on the Thai-Cambodian border. Dr. Kain's research efforts are focused on developing a translational research program that characterizes host-parasite interactions responsible for major global infectious disease threats, particularly as they pertain to maternal-child health. Dr. Kain's efforts are also focused on global equity, knowledge and sharing and education, including the transfer of appropriate technologies and the training of research scientists in low and middle income countries, enabling and empowering them to address their own problems in a sustainable fashion. Dr. Kain has received several awards, including but not limited to the C. Wolf Award for Excellence in Teaching at the University of Toronto, a Career Scientist Award from the Ontario Ministry of Health, the Bailey K. Ashford Medal from the American Society for Tropical Medicine and Hygiene for his distinguished work in tropical medicine, and was profiled by Time Magazine as one of Canada's best in medicine. So, Dr. Kain, thank you so much for speaking to us today at the University of Washington. We're really looking forward to your talk.
Thanks so much, Jason.
And Kevin, could I tell people that if you have questions, please put them in the chat, and Tess King will be monitoring the chat and can ask the questions at the end of Dr. Kain's lecture. Sorry, Kevin.
Okay, thanks so much, Jason, and thank you for the kind invitation to speak. I think that this is a very interesting time in infectious diseases for a variety of reasons. But I've always been fascinated with, particularly working in low resource centers where two children will come in with malaria and yet one will progress rapidly to severe and fatal outcome while other has a very uncomplicated course. And it seems just logical at a very basic level that there's more going on than just the pathogen and that our response to it has to play a critical role. However, we really have largely ignored host response in terms of how to understand it, how to modify it outside of steroids. We are very fascinated as infectious disease people, obviously, in microbes, but almost to the point where we're creating diagnostics at a rate and a distribution in our hospitals and even to the public that's pushing us into not really knowing what it means. Obviously, you can be contaminated with microbes all the way to life-threatening infections. And I think as clinicians, what we really need to know is, yeah, you may have, pathogen X, but are you going to become ill and are you going to become critically ill? And do I need to modify my triage and referral and admission practices on you urgently? We're now rolling out a lot of these rapid diagnostic tests without a clear understanding whether they really impact care. So you clearly would know that respiratory tract infections are a leading cause of inappropriate antimicrobial use. So just one study of many coming out now that's looked at antibiotic stewardship by using rapid respiratory pathogen testing. And the bottom line is it's not clear, at least in this study and others, whether it does anything to reduce antibiotic use. Similarly, we use antibiotics assuming we treat really only for one desirable reason, and that's to decrease disability and death. But when you actually look at something like pneumonia, leading cause of childhood death in the world, and the WHO's recommendation of Amoxil for children that have criteria that indicate pneumonia, it isn't clear that we improve outcomes. So this is Amy Ginsburg, who was actually in Seattle for a long time, did a nice randomized double-blind placebo-controlled trial of Amoxil versus placebo for pneumonia and Malawian children. And the bottom line was that there was very little difference between the antimicrobial versus placebo outcomes. 93% of those that received placebo resolved to day 14 with no difference in groups. And the conclusions are, I think we all appreciate that we're considerably over-treating respiratory tract infections. And what we really need are better ways of identifying children and adults who would actually benefit from antibiotic therapy. And consequently, we need better risk stratification tools. Now, if only we'd listen to Sir William. So instead of looking for bugs and their genetic determinants that might or might not confer virulence, Sir William Osler, a good Canadian who was born just outside of Toronto, said in 1904, it appears that patients are dying not from their infections, but rather their reactions to them. So, of course, Sir William was right on the money. It took the rest of our field about 120 years to reach that conclusion, that in fact, sepsis is agnostic to pathogen, and that it's a dysregulated host response, including malaria. So in this talk, I'm going to use malaria as a model, but I think it is a model of all life-threatening infections. So I'll talk a little bit about the reaction that we're interested in is what infections do to microvasculature. So you've got about 100,000 kilometers of blood vessels. I have to translate that into miles. What is 63,000 miles of blood vessels? And I'm going to argue that infections lead to severity and death because of their impact on microvasculature and its dysfunction. Similarly, there's only one time in your life where you ever grow a new organ, and that's if you become pregnant and you have to vascularize that placenta. So again, looking at how infections during pregnancy might alter the development of blood vessels that are essential to support the exponential fetal growth during pregnancy. I always try and tell people exactly what I'm going to try and convince them of. So I'm going to try and convince you, you can tell me whether I was successful or not at the end, that there is now, I believe, a next generation of host-based triage tools based on markers of vascular injury that may enable early recognition of severe infections. And that because these are mechanistic pathways, it also allows us to risk stratify people in order for novel therapies to protect the vasculature. Well, let me make this as a case-based approach. So our focus is in maternal child health because to me, impact in terms of global health is not what impact factor your journal article was, but rather the 3 Ds: deaths, disabilities, and dollars. And how do we decrease deaths, disabilities, and dollars? And it's always going to have the greatest impact in maternal child health. So here's a case in Canada of a young woman that went to Southern Africa and had a holiday, returned, presented to the emergency department because she developed a fever after this holiday. On examination, it's unremarkable. She's clinically stable. They do what we do everywhere now, including everywhere in low and middle income countries. She gets a rapid diagnostic point of care test for malaria, and it's positive. And she's given an oral agent, atovaquone proguanil, which is a good antimalarial for uncomplicated malaria. The family comes to you and says, how is she going to do? And here's your potential answers. We'll do well with less than 1% chance of death, 5%, 7%, 10%, greater than 18%. Well, unfortunately, with this young woman, it was the 18 and over. Over the next 12 hours, she deteriorates. And the point here is malaria rapid diagnostic tests have transformed how we recognize malaria, but they don't tell you anything about the severity of infection. This required multiple helicopter transfers. She developed acute kidney injury, lactic acidosis, and died. So failure to recognize impending critical illness, even when you have a point-of-care rapid diagnostic test. Give you another case example of a case that I saw. Physician mom takes her 9-year-old son on a Kenyan safari for 10 days, decides it's short, they're going to use insect repellents and not take chemoprophylaxis. The child develops a febrile illness, becomes confused, altered, and then has seizures, is taken promptly to a hospital and treated with parenteral artesunate, which is the appropriate drug, responds, and they return home. So the mom asks you what the prognosis for this child is. Will he have any lasting effects? No long-term impact expected, 5% chance of neurocognitive deficits, 10%, 20%. It's actually over 50%. So if you look at Terry Taylor and her group in Malawi's very long-term evaluation, over 50% of children that develop cerebral malaria will have measurable neuro and developmental defects following that. And we don't have anything that's neuroprotective. Obviously, we're killing the pathogen, but we're not modifying the host in a way that would protect the blood-brain barrier and mitigate neurological injury. And I really, in case you're not aware of this literature, it's fascinating. I'll just show a few examples here, but there's been a number of studies, most coming out of Scandinavia because they have such good population-based capacity. Just one example, so 1 million plus people followed for 9 million person years, with the exposure being an infection in childhood that required either admission or an antibiotic. And those were associated with an increased risk for a whole series of neuropsychiatric disorders: autism spectrum disorder, schizophrenia, bipolar, attention deficit disorders. So this idea that we've been kind of taught over the last 20 years that there's communicable diseases and non-communicable diseases, and they don't really mix. But I think that is a false dichotomy, and we're now learning that infections in childhood are certainly induce increased risk for neuropsychiatric disorders in follow-up. And there are many studies out there. So to me, the problems are self-evident, but not addressed very well. Everybody gets infections. 2 billion people a year get a febrile illness. Children in Africa get a mean of almost 6 febrile illnesses per year under age 5. I think as clinicians, we all recognize, sepsis, septic shock when it's in front of us. What we lack are early tools to recognize someone before it becomes clinically apparent. Because once they are septic, we have poor outcomes, even in high income settings, and even despite heroic measures. And now we're learning about the burden of neurocognitive and neuropsychiatric disorders. And we have no specific treatments other than supportive to improve outcome. So that barrier in severe infection clearly leads to increased mortality. It also, at the other end of the spectrum, misallocates resources because we're admitting, we're diagnosing, we're treating, we're supporting the majority of people that have self-limited infections. And that's not benign. There's no reason to ever be in a hospital unless there's some benefit. There's no tangible benefit to be in a hospital with a self-limited infection. Causes harm, healthcare costs, colonization, antimicrobial resistance. The other barrier that we deal with in low and middle or low resource settings is that the majority of children, for example, in sub-Saharan Africa, will die without ever engaging the formal healthcare sector. So, building capacity in emergency departments won't necessarily have impact. Impact requires something that can be implemented at the community level, where there aren't physicians and trained nurses necessarily, just volunteer workers. So we need a simple integrated approach for the febrile child, not a pathogen-based approach. And I think malaria is teaching us that. So right now, when children get fever in sub-Saharan Africa, they get given an RDT, which is, again, a good test. It doesn't tell you who's developing severe malaria. And if it's negative, in studies, up to 70% or more of the children who are RDT negative for malaria are given antibiotics. So this is not a sustainable solution. What we really need to know early is who's developing severe malaria, therefore needs referral admission and parenteral artesunate. And this is not easy to do. So one study, WHO did a whole training program in Uganda across 105 health centers and then followed up a year later. And unfortunately, despite that training effort, a referral was appropriate in less than 10%, and prompt diagnosis and treatment for severe malarias was less than 30%. So again, the triage is the rate limiting step, and we're not immune to that. I'll just show this year's MMWR for malaria in the US. You've got the most malaria you've had in 45 years. There's a significant increases in severe malaria. It's significantly more common in children than adults, and it was significantly more likely to be mismanaged. Less than 50% of people, based on reported US data, had appropriate treatment for severe malaria. But where rubber really hits the road, obviously, in our context, is sepsis. And again, this is hard. Early in the course of sepsis may be very, very difficult to determine who is going to track towards a critical illness. It's always in the top 3 causes of successful lawsuits brought against physicians in the US, particularly in emergency departments and in pediatrics. But it's hard. I mean, there's been a number of studies. Just one example of a Canadian study of 2 different academic hospitals, which followed up all the patients that presented to emerge and what happened to them. Only half of the patients requiring ICU were recognized on their first emergency department visit. Recognizing sepsis early was challenging. And the bottom line is that turned into a doubling of death and a 5 times increase in healthcare costs. So again, better triage tools. Without good triage tools, we can overwhelm health resources pretty quickly. COVID is another example. How do we know who's going to have self-limited, or who's going to need oxygen, who's going to deteriorate? So to us, the critical knowledge gaps are when we see a febrile patient, who's going to get critically ill, who needs referral admission, who would benefit from critical care. And given that we're now moving into very high value therapeutics, and monoclonal antibodies are everywhere now, who would benefit from them, and is it cost effective? Literally no country in the world can afford their healthcare system. So it's really about maximizing impact, 3 Ds with that. So how do we address that? Well, there's many ways you could address it. Conrad and I and others for probably 20 years have approached it from this idea that yes, malaria is not E. coli, is not a toxin, is not dengue, is not a filovirus, but in fact, they may all kill you by a common pathway, and that's microvascular injury. Therefore, if we were seeing a patient early, the first clinical presentation, and if we measured markers that are reflective of endothelial dysfunction and immune activation, could we identify those tracking to sepsis? And perhaps rather excitingly, could we also have then, so it's a one-style approach for multiple pathways, or one pathway caused by multiple agents. And therefore, could we also have an agnostic intervention that would stabilize microvasculature and improve outcome? So that sounds easy to say and hard to prove. And given this statement by the former research director of our NIH, who said the majority of biomedical research does not help anyone anywhere at any time, we try to approach this in a slightly different way to at least try and enhance the fact that these will turn into useful things. So field side is not a bench to bench side. It's in the field, back to the bench and back to the field side. So this idea that if you think, well, I think this pathway is critical to inducing sepsis or some other important outcome, showing real people with real disease that pathway is associated with the outcome of interest. That's association. It's very difficult, obviously, to establish causality. If you want to understand mechanism and causality, you attempt to move to preclinical models, but only if the model behaves exactly like the humans do. And those, of course, you can do things, gene knockouts and interventions, et cetera, and imaging that would be very difficult to do in a low resource setting. And you can also use those models to evaluate. And for us, it's not expensive new agents. We think about repurposing or repositioning agents that are already known to be safe and effective and lower the cost. But to close this loop and have impact, you have to go back to the same high-risk populations and do randomized clinical trials. So we've attempted to do that in our studies in sub-Saharan Africa. This is our Jinja, Uganda, Canadian, and Ugandan team. And this is the pediatric hospital in Jinja, the source of the Nile. And it says kind of a typical problem. When you walk in, there's one nurse, the rest of the moms, half the children, you look at them and go, why is that child in here? They don't look ill at all. The other ones are moribund. You overwhelm health research capacity and you have bad outcomes. So in order to do studies, we had to build our own ICU, a lot of community engagement, as you know, which is critical, education. And then what we do is risk stratify, and I'll give you some more details in a sec. And then based on these markers, and then intervene on therapeutic strategies based on those pathways to improve outcome. So let me give you one example of how we try to validate these markers that ultimately we would like to put into a point of care device. So this is a study led by Andrea Conroy and Michael Hawks, who are doing PhDs in the lab. Conrad is a collaborator in this. We took consecutive children presenting with fever, every child at their first presentation, and we analyzed a whole series, 14 different markers that we thought mechanistically were important for vascular protection. So this is one marker, it's called STRAM, or triggering receptor on myeloid cells, which is an immune activation marker and for which therapeutics actually exist. And these are the number of children, and this is increasing levels of STRAM, and this is their mortality rates. And what we were able to do was show that there's kind of two logical breakpoints in this STRAM level. So we called that the green zone, which was associated with a negative likelihood ratio of less than 0.05. So your pretest probability, this is 20 times lower than that. And that cutoff allowed about 50% of the children to have not been admitted to hospital. We haven't done that particular study, we're doing it now. It also identified another cutoff where we called the red zone, where the case fatality rate with a positive likelihood ratio was greater than 10. In fact, the case fatality rate in this group was 100 times higher than in this group. You can see that going up to 68 or greater %. So it allowed you to sort of think, and we did that in a developmental set and a validation set, that if you had two cutoffs on a point of care, you could risk stratify the green kids home, the yellow for admission and monitoring, and the red zone children for urgent intervention and care. If you look at that now combined data, it very nicely matched. And I'm just showing you the Kaplan-Meier survivals for both malaria in the top and non-malaria infection. And you see that it was very good for malaria, virtually nobody in that green group. These are samples taken at presentation. And the red group obviously had greater mortality, but we're finding in most places that malaria children do better than non-malaria febrile illnesses. We also extended this to look at things like pneumonia as a leading cause of death. And I'm just showing you area under the rock curves. I'm assuming you're familiar with them, but if you're not, it's just a good way to show how a diagnostic or risk stratification tool performs. This is the sensitivity on the vertical axis, and the specific 1- specificity or false positives on the bottom. And a very good diagnostic test would have an area under the rock curve over 0.8 or would be outstanding over 0.9. Less than 0.7 is not. So sorry. This is children with IM, integrated management of childhood illness, defined pneumonia. And STRAM was an excellent test for predicting at presentation the child would go on to a severe or fatal outcome, versus pulse oximetry, respiratory rate, or combinations, which were poor tests. We also looked at lactate, which is probably the best, but it was also inferior to TREM. And we looked at the acute phase proteins, CRP and PCT, which really were poor and not reliable at all. So where we are now is this idea where everybody basically in Southeast Asia, South Asia gets a malaria RDT. And could we now empower these to tell us not only whether you have malaria, but whether you need to be referred? So the idea, if you had a severity marker threshold incorporated into the same RDT, when your malaria was positive, it would tell you whether if the severity marker was negative, you could be managed as an outpatient on oral ACTs. And if the severity marker was positive, then it would be a criteria for referral, admission, and IV artesunate. These markers are quantitative independent predictors of mortality. Similarly, if the malaria is negative, it would help you identify the children that still need to be referred with sepsis and would be appropriate to cover with antimicrobials versus those that have no malaria, no severity marker, managed as outpatients with antipyretics and follow-up. So it goes back to this idea that, not mine, obviously, but well stated. The holy grail is to have early warning systems in place that accurately flag all febrile patients who are at risk for deterioration. Such patients should be prioritized for care. And so what we have now is a way of at least this approach to try and empower point of care testing to triage all-cause fever syndromes, which is the clinical problem. And also addressing evidence-based gender inequity and access to care. We know in a number of countries, girls with fever are taken later. They're triaged slower. And then the last part of this storyline is that these markers tell you underlying pathways that are mediating host injury, and therefore they're druggable. So you have a linked approach between risk stratification, identifying the kids at risk, but also interventions. So we're exploring that right now with Kiki Bassett, our collaborator, IS Global in Manisa, in Mozambique, where we risk stratify children based on this. And because they have demographic surveillance, any child that has no severity marker, no malaria, who's sent home gets followed up every day to show that that's safe. And the ones that are shown to be high risk, we've enrolled into a randomized double-blind placebo-controlled trial of PPAR gamma agonists, because we'd shown that these repurposed drugs that are off patent induce neuroprotective pathways in humans with malaria and improve outcomes in preclinical models. So we've enrolled children with severe malaria and also followed them for 2 years to see if we improve their neurological outcome. So switching trajectory now to what happens in the context of pregnancy and infections, and how can we exploit that to improve our management of infections in pregnancy. So another case to set the stage, this is in Madagascar, the Baobabs, a young Canadian woman, 16 weeks pregnant, visits Madagascar. She doesn't use chemoprophylaxis. She gets a fever after she comes home. She goes to the emergency department. Again, she's diagnosed with P. falciparum and given an ACT, and she responds well. She asks you whether the baby is at risk for any adverse outcome. So here's your options. Promptly treated, no problems. The baby has an increased risk for preterm birth. The baby is at increased risk for brain injury and neuropsychiatric disorders, and she should eat peanuts. We'll come back to that one. And the answer, I'll try and convince you, is all three. So again, bottom line up front, malaria and pregnancy, or MIP, but I'm gonna try and convince you also that this isn't specific to malaria. It could be flu, it could be anything in pregnancy. Induces host responses that contribute in poor birth outcomes. That it can cause brain injury in offspring that's independent of their birth weight or prematurity. So a child that is normal birth weight with no other mitigating features could still have brain injury because of even a treated infection during pregnancy. And again, if we modify these host responses, can we decrease these risks? But to have impact, it's going to have to be safe and affordable and suitable for implementation in low resource settings. So most people, I think, don't know how many babies are born every year. So it varies, of course, but there's about 130 million babies born every year. So my question is, how many of those babies do you think are born in low resource settings, low and middle income countries? Well, the answer is it's the great majority of them. So the future of our planet right now, given all our troubles, will depend on children born in low and middle income countries right now and the likelihood they will reach their intellectual potential. So what's preventing them from reaching their intellectual potential way too often? One of these things is preterm birth. So this is now the leading cause of death in children under 5 in the world. There's about 15 million preterm births, and at least 1 million of those die. The great majority of these occur in low resource settings, particularly in Africa. Malawi, for example, where we work, 20% of all births are preterm. So again, the approach here is, can we use markers of vascular development to identify women at risk? And can we intervene to improve birth outcomes and prevent brain injury in survivors? Because we don't have many tools. So how does this work, and what are the mechanisms? There's a very large number of pregnant women at risk of malaria, 125 million every year. And there's at least 200,000 deaths associated with the typical adverse birth outcomes, low birth weight or fetal growth restriction, preterm birth, and stillbirth. The other interesting point here is, despite this death, there are millions of children that are exposed in utero and are born without a birth phenotype. Are they also at risk? So how do we approach that? Well, we got very interested in complement. Why? Well, you all know what complement is. You're taught the cascades, and you cleave C5 and make C5b, the membrane attack complex, which then goes on and kills encapsulated bacteria. But we're learning that as infectious disease people, we don't realize that a lot of these things that we think of as being primarily important for infections like TNF and IL-6, so inflammatory markers, complement, actually have critical neurodevelopmental roles. So we got interested in the role of a complement in terms of brain injury several years ago. And in vitro studies showed that it also dysregulated angiogenic factors. So like I said, there's all these pathways. Pathogens can directly cleave. Malaria can directly cleave C5, generating C5b, but also this nasty little anaphylatoxin, C5a, which induces inflammation, synergistically dysregulated angiogenesis and procoagulant. So we had this hypothesis. Actually, this was Andrea Conroy, a PhD student's hypothesis, that complement activation contributes. This is the trigger. So the simple hypothesis was that malaria increases C5a, and that dysregulates angiogenesis and inflammation. Therefore, you can't adequately vascularize your placenta. And if you can't massively increase the delivery of oxygen and nutrients, you will get a stillborn baby or a low birth weight baby or a preterm baby. So to follow our model, Andrea went to Malawi and worked there, asking initially simple questions in collaboration with Stephen Rogerson and Malcolm Molyu from Liverpool and University of Melbourne, and did a case control study and asked simple questions. Well, for starters, is C5 even associated with malaria and with adverse birth outcomes? And the answers are, it is. So the more malaria you have, the higher your circulating levels of C5a in the placenta and peripherally. And the higher the levels, the more likely you are to have a low birth weight infant. So how can complement precisely affect vascular growth? Well, all of these, normally your blood vessels are stable. When you sprout them and grow them in the placenta, you have to destabilize them. So things like angiopoietin 2 destabilizes and allows you to sprout. So the next question Andrea asked was, are these changes in angiogenic proteins associated with disease? And the bottom line, they are. And what you saw is an increase in anti-angiogenic factors, so things that were inhibiting blood vessel development. And so the other way we tried to show causality was in a thing called structural equation modeling using human data. But because we could show that the mouse model behaved the same way, we did a more definitive way of establishing causality. So we used a mouse model, gave them malaria when they were pregnant, looked at their birth outcomes, and then we're able to look using micro CT imaging how it affected their placental vascularization. And then we could use an antibody to block C5a, or we knocked out the receptor. So pharmacologically and genetically, we established causality. And you don't need stats to see this. So this is, these are placentas from mice that are imaged in 3 dimensions that didn't show up here. But you can see that there's way more vessels here than here. Both of these mice are infected with malaria at the same level. None of the mice are treated for the malaria, but in this case, we've either knocked out C5AR, the receptor for C5a, or we blocked it with an antibody. It grows more vessels and you improve birth outcomes. So now we have this kind of model where the parasites are inducing mononuclear cells, which are inducing C5a, which dysregulates angiogenesis and leads to these birth outcomes. So that's cool, but how do we use that information to impact? And so the idea here was, can we use it early at their first antenatal visit to identify women at risk? And so this is a paper from last year. Robin Elphinstone was an MD PhD student and asked that question. And it was pretty fascinating. So what we did was, and this is in Malawi, all pregnant women, as you probably know, at their first antenatal visit around 24 weeks are given intermittent preventive therapy. And that usually decreases low birth weight children, but doesn't seem to have any impact on preterm birth. So people have argued, we don't think malaria causes preterm birth. So we followed, in collaboration with Mway from the Malawian College of Medicine and Fico Terkul from Liverpool, 1,628 women, and collected samples across pregnancy. And what Robin was able to show was that at first presentation before 24 weeks, 40% of these women were subclinically infected with malaria. So before they started their IPT. And even though many of them, most of them, never had another episode of malaria, those women were at significant increased risk of preterm birth. And so the reason the WHO policy of IPT may not be having an effect on preterm birth is because it started too little too late. So what do those data look like? So this is the gestational age. So women are coming in, 14 to 16 weeks. And this is a woman that has one episode of malaria, and that's the red bars and the 95% confidence versus women that never had malaria. And you can see that even one episode dysregulates these critical factors, often over the entire course of pregnancy. So once it's become dysregulated, it does not recover. This is also, to go to my general theme, exactly what we also see in HIV in pregnancy. You get the same effect where the anti-angiogenic factors take over, and then they're associated with so here's women that had higher levels of anti-angiogenic factors were at increased risk for preterm birth and stillbirth, and if they had lower levels of pro-angiogenic factors. So again, the same pathways across. So how could we do something about this? Well, we actually, as you know, have an FDA-approved monoclonal antibody that's safe in pregnancy that acts on this pathway. The only problem, of course, is it's the most outrageously overpriced, according to Lancet, outrageously overpriced orphan drug there is. A treatment course, unless you have a deal, is almost $410,000. So that's not going to help a lot of people, certainly in low resource settings. So how do you normally regulate blood vessel development and keep it quiescent? It's nitric oxide. And how do you make nitric oxide? Well, either through L-arginine, which is a nutritionally essential amino acid in pregnancy, nitric oxide synthases. We're talking about endothelial nitric oxide synthases, not macrophage inducible. And so L-arginine or L-citrulline, which is converted into L-arginine in vivo, is the substrate by which you generate. So if you're a poor pregnant woman in rural Africa, this is dietary. So, and it's primarily found in meat and fish, not something that's widely available. So you're often deficient, hypothesis, deficient nutritionally. And then malaria makes red cells lyse, so you get arginase. So there's a bunch of reasons why you might not have enough L-arginine to make enough nitric oxide to actually regulate the placental vascular development. So that was our hypothesis. So again, start with humans. So working with Wafai Fauzi at Harvard School of Public Health, we did a large study of over 7,000 pregnant women in Tanzania and did detailed dietary L-arginine, L-citrulline, and then looked at the outcomes associated with their dietary histories. And the bottom line was the more L-arginine women took in, the lower their risk of preterm birth. So most people in the audience there would be eating, 5,000 milligrams a day. And as soon as that dropped below about 2,000 in Africa, the rate of preterm birth, of preterm delivery, really climbed. So how did we then establish an approach that was feasible and affordable and safe? So this is Chloe McDonald's PhD study, and what Chloe was able to show, again, start with women and show that their L-arginine is affected by even one episode of malaria, that's the red line, significantly. And once it's affected, it stays affected over all of gestation. And it's associated with inhibitors of nitric oxide synthase, ADMA. And that is associated with a low birth weight baby. Then we moved into an animal model and showed that if you take mice and give them a low arginine diet and give them malaria, they get preterm birth and they have about 50% stillbirth rates. If you don't treat their malaria at all, but simply supplement them with L-arginine in their drinking water, you completely rescue stillbirths and significantly improve preventing preterm birth and fetal growth restriction in that model. And it's because they're doing the same thing in the placenta. That arginine is decreasing complement expression. It's increasing Tie2, which is bound by Ang1, which stabilizes blood vessels. It decreases Ang2, which destabilizes. So all of it made sense. So the bottom line is that we were able to grow as many vessels for something that cost peanuts, literally, versus a $400,000 monoclonal antibody approach to the problem. And the other thing that we always have to think about in low income settings is sustainability. Well, it turns out that L-arginine is found in things that are expensive, but it's also found in groundnuts. And women's groups frequently grow groundnuts, peanuts, as cash crops. So thinking about a way to make this sustainable. And that then links to the study that we're now doing. And this is being led by an MD ID physician who's doing her PhD. And the goal here is to, and we're starting in January, conduct the AGREE trial, which is a placebo-controlled, double-blind of oral arginine and citrulline in 2,800 pregnant women in Kisumu in collaboration with Phycoterra Cool and Helen Barsosio from Kemri. And the primary outcome will be a reduction in all-cause adverse birth outcomes, and we'll do neurocognitive outcome on offspring. So this is my summary slide. So we think that understanding mechanism helps us identify ways of risk stratifying women early in pregnancy for preterm birth. Decreased L-arginine is associated with an increased risk of preterm birth. It's safe, it's inexpensive in pregnancy. And L-arginine supplementation or L-citrulline supplementation, as I said, is less likely to be eaten up in the gut, enhances placental vascular development and improves birth outcomes in a preclinical model. So that is the next step. And then finally, in the last few minutes, just a word on global inequity. We hear a lot about inequity, but it's never more bearing than when one visits these low resource settings. So the vast majority, 95% of children with developmental disabilities live in low and middle income countries, especially sub-Saharan Africa. Sub-Saharan Africa has the highest rates of hearing and vision loss, epilepsy, and intellectual disabilities. Approximately 50% of children exhibit developmental delays. And so hard to build economies, hard to build productive societies with this burden on these poor children, not to mention the cost. So how and why are these children at such risk of neurocognitive? Partly it has to do with some of these birth things. Low birth weight children, preterm birth children are at high risk for poor neurodevelopmental outcomes. But even without that, we showed in an animal model that even low amounts of malaria, no effect on birth outcome, induces neurocognitive impairment in a preclinical model. And it actually alters neurodevelopment and neurovascular development. So we needed to now translate this to the human scenario, and this got published just this week, actually. So Andrea Weckman was the graduate student that did it and was able to show by following over 420 mom-babe dyads for 2 years and doing validated neurocognitive tests, is that if mom had malaria in pregnancy, and we also followed her inflammatory mediators across pregnancy, even without a birth phenotype, that child was at significant risk of neurocognitive impairment. And mechanistically, it was linked to immune activation in the mom, the same hypothesis, particularly soluble TNFR2. And you might know that as an inflammatory mediator, but the TNF pathway is critical for axon and neuron development. And IL-6 was also elevated, and it's critical for neural stem cell differentiation and localization in the brain. So you can see how these infection-driven problems can alter brain development in this child. So the good news is this is modifiable. We can do something about this. That's Andrea there. And then again, this is a broad problem. So again, there's multiple studies out now. Here's just one example. Swedish study, 1.8 million children followed for out to 41 years. Again, the exposure was now a maternal infection during pregnancy. And it was associated again with ASD, major depressive illness, and even an increased suicide risk. So this idea that these are modifiable risk factors for what would otherwise be lifelong disabilities. And I think that's the really exciting thing here. We don't tend to think of these things as being any way related to infection. But in fact, if they occur during that critical neurodevelopmental window, via inflammation, they become something we can do something about. So again, I think that is an exciting idea because, again, modifiable. So overall summary, patient outcomes matter. Pathogens are cool, but it matters more what happens to the people we're looking after. And we need better triage tools in all healthcare environments. It's hard to recognize severe infections until they're severe, but that is too late. And that results in increased mortality and morbidity in all healthcare environments. We're optimistic, but need to prove that if we could integrate severity markers into point of care, even malaria rapid diagnostic tests, it may address this serious gap and gender inequity. But of course, we have to prove that. And I think an exciting idea is that preventing infections in pregnancy may be the most cost-effective way of inducing or reducing non-communicable disease. So I'd like to thank all of the lab members and our collaborators, including Conrad, that did all that work that I showed. And I appreciate your attention. Thank you.
Thank you so much, Dr. Kain. That was a great talk. I have a few questions that have come in through our chat, and we can certainly take more. We've got a little over 10 minutes here. So I'll just start asking them as they've come in. So we have a question here saying that predicting which hospitalized patients will develop sepsis using electronic health record tools has been disappointing when studied using RCTs and invalidation studies. There's concern that we're missing important early clues at the early stages of sepsis, and we're focusing too much on the late manifestations, such as tachycardia and other vital signs. So the question is that, do you have any advice on what we might be able to do to find these patients at a time when we can prevent serious illness and death?
Yes, I mean, I think the clinic, obviously we don't want to lose our clinical skills, but I think the clinical symptoms and signs are going to be delayed. And that's why we think this approach makes more sense. And we know this from animal models. So the animals have these same vascular injury markers. And so if we give an animal a lethal injection and it looks fine, 48 hours before the animal is showing any kind of critical illness, 48 hours before, these markers tell us that the outcome. They're quantitative and independent predictors of mortality. So I think that it's going to be difficult to maintain a clinical symptom sign health record approach to finding these people early. So that's why, we think this is a more pragmatic and more globally implementable strategy. It would be to have a point of care test to help inform, not to remove clinical by any means, but to inform. And that's why using likelihood ratios. If you were going to send this child home and this severity marker tells you this child is 10 times more likely to die than you thought, that can change management. So I think this is an approach, but obviously it needs to be proven in rigorous prospective studies.
Great, thank you so much. There are also a couple of different questions getting at this idea about COVID. And so I think the general question is, are there parallels or evidence that you've seen that have come out at all with similar mechanisms for the role that COVID and its complications play for mothers who are infected, for women who are infected while they're pregnant?
Right. So we've done a couple of studies, as have others, and these same markers that we're looking at, S-TRAM and angiopoietin-2, are pretty good predictors at presentation of COVID severity, who will end up in ICU, who will end up intubated, who will die within 30 days. And in pregnancy, and it's interesting, COVID actually causes a lot of microvascular injury, thrombotic microangiopathy. It's a lot like malaria in some ways, fibrin microthrombi. And so what we're doing right now, we're funded to study COVID in pregnancy, and other groups are doing this as well, with or without HIV and with or without malaria, because those would be the two most common co-infections. So the question is, does COVID make malaria in pregnancy worse or vice versa, or HIV, or is it more likely to cause vertical transmission, et cetera, et cetera? So those studies are underway. We're collaborating with the CDC and Kasumu, and I think we just are receiving somewhere around 4,000 samples to sort of ask these questions. We haven't got any data right now, but it's fascinating to see what the interactions will be when you have these other two co-infections.
So we'll have to stay tuned for that, it sounds like. And then there's a question about aspirin and preterm delivery. So someone's saying, last year there was a study that came out about aspirin 81 milligrams for preterm labor prophylaxis in low middle income pregnant people. Do you think that the mechanism for aspirin and preterm labor prophylaxis is at all related to the placental response to infection?
It's a good question, and I do not have an answer. Obviously, it's an antipyretic, so that would make some assumptions that it's impacting some of these inflammatory mediators. But we've not specifically looked at it, so I can't give details. So this was preterm birth. Did you say?
I think it was for preterm labor prophylaxis. So.
Oh, prophylaxis. Okay. No, that's interesting. I don't have any specific data. It'd be interesting if they collected samples in those women to look at whether it influences any of these angiogenic or inflammatory mediators, because it's not rocket science. If you're developing an anti-angiogenic profile, it's anti-angiogenic means you're creating a situation where you're mitigating or you're preventing vasculature from developing, and if it prevents that, we'd expect to see it reflected in the increase of pro-angiogenic and the decrease in anti-angiogenic factors.
And kind of along those same lines, another question about a specific medication. So sildenafil has been shown to increase vascular nitric oxide levels by blocking its intracellular degradation. And so this question is just asking, could a drug similar to that have therapeutic benefit for the conditions that you were addressing before?
Yeah, I mean, that's interesting. I've heard that before. I guess there's advantages, particularly in the West, for that kind of strategy. We were trying to think of something that was more sort of sustainable, that, if we can use just a single amino acid that should be in our diet anyway, that's essential in our diet, that's sustainable, it was more attractive. That doesn't mean looking at, other therapeutic approaches wouldn't be informative. We just haven't done it, so I can't speak specifically to that. And I don't know if those studies have looked at the same mediators, but it is an interesting story.
And then taking a slightly different turn, earlier in your talk, you mentioned that the malaria cases in the US have been up highest that they have been in the past 45 years. Just wondering if you could go back and just speak to any reasoning for, why that might be, or what, what's going on to cause that dramatic rise.
Yeah, I mean, I leapt over that. I think it used to be a lot of new migrants and stuff, but this is now more US citizens and VFRs. So people that are now, naturalized citizens or residents in the US going back to visit. I don't know, can't find it now. So it's been a change from just migrants coming in with malaria. So this is mostly, people that are legally in the country, and it's got to do with VFRs, visiting family and friends. So people that have immigrated years ago but continue to go back and don't take prophylaxis or don't take it properly, are at risk. So, but those numbers, like, they're really climbing. If I could find the slide, I can put it back up. I can't even see it. Sorry, it's in here somewhere. Apologies. But that's that's just the MMWR this year, and they go through a lot of case reports about the fatal outcomes. So I think it's interesting reading. Although I think the greater burden of the problem is going to be with sepsis in children and in adults in North America.
Great. Well, thank you so much for your time. I think we've gone through all the questions that have been posed. So thank you so much for your time. Thanks so much for putting this presentation together. Super interesting. And I think that just for your reference, I think that the article that was referenced before about the aspirin and preterm labor is in our chat that you can probably see. So thank you so much, and have a wonderful rest of your day, everyone.
Okay, thanks. Bye.
See you later, Kevin.
See you,
Bye-bye.
Kevin. Thank you so much. It was great.
You're welcome.